Quality measures are interesting because they've been around for a while, and there have been a lot of discussions about how to do this best. I will share with you that I serve on the Cancer Standing Committee. It's one of the quality committees from the NQF, the national quality folks. And they vet very carefully in a public process, in a very detailed process. Like having sat through the meetings, I can attest to that, whether or not a quality measure is ready for prime time. And then CMS takes that quality measure, and sometimes CMS takes it without the NQF seal of approval. I actually go back to the day I sat in a fairly large meeting a number of years ago when the quality measure was as basic as taking blood pressure when a patient walks into the office. I mean, we've come a long way. Or when do you do a skin exam for a patient that has a diagnosis of melanoma? Those are kinds of early quality measures. So NQF does it, and the AMA does it, and professional societies do it, and ultimately we try to be as evidence-based as we possibly can. And as I said, the NQF process is very rigorous in whether it accepts, and there's a lot of opportunity for public comment. The AMA has a process where they have room for public comment. But I'll tell you where the problem is from my perspective. The problem, and I'm not alone on this, the problem is it's not just about the point in time. Did a woman get her mammogram at an appropriate interval? It's a process of care. Is that woman, number one, at high risk or average risk? If she's at average risk, did she get a mammogram consistent with recognized guidelines? There are various ones. American Cancer Society has some, the task force, for the service task force has other. But the point isn't, I'm not getting into that discussion. What I am saying is, did she get her mammogram? If she had an abnormal mammogram, what was the outcome of that? If it turned out that she had cancer, did she get the right follow-up test? Did she get it in a timely way? If she had cancer and then the treatment, is the treatment appropriate for what happens? And then did the radiation therapy start at the right time? Did the medication, the chemotherapy, or the hormonal therapy start at the right time? And was she followed up appropriately? That's a process. That's what we should be doing. When we talk about all these EMR systems, electronic medical records, we talk about them, why can't we really do quality? Why can't we make sure that people have access to care? Why can't we make sure that if they have a problem, that the care is the right care? And then why can't we know what the outcome is for that person? That's a big change. And with everybody talking, you hear all this stuff about health information technology, electronic medical records, artificial intelligence, all those things. And yet we can't, now some institutions may be able to, but many patients go from place A to place B to place C to place D, and nobody links it together. And who's the worse off for it? The person getting the care. We can do much better.
Do you expect value frameworks, this is the last question in this section, do you expect value frameworks such as those developed by ASCO, NCCN, and ICER to influence patient-centered care? If so, how do they?
Value frameworks are being established by organizations like the National Comprehensive Cancer Network, NCCN, and ASCO, and others. And they're a work in progress. Sometimes you see them, and I will share that when we looked at some of the original ASCO work, we did have some problems with it. We shared our opinion. When I say we, I mean the American Cancer Society. But we got to start somewhere. Now, the question becomes, what's the value and who establishes that rule? And some will say, ICER's had some criticism, saying that perhaps they're too strict. Others say ICER's doing a great job. I'm not taking one side or the other on that. But one person's value may be another person's life. And we've had a long history in medicine in this country, of letting people make decisions for themselves without that restriction. And so, no easy answer, but at some point, we're going to have to figure out how to make this work. And it's not just keep by opening the spigot more and more, because that spigot is endless. What we don't do a good job, let's put aside ASCO, let's put aside ICER and NCCN for the moment. What we don't do a good job is necessarily following the evidence. And it's not just in oncology and cancer care, but it's in many other areas of medicine. Why are we still doing some of the things we do when the evidence doesn't support the fact we should be doing it? Because we've always done it that way? That's not where we should be. And there's been a slow transition. No, medicine changes over decades. It doesn't change sometimes it changes overnight. Sometimes evidence comes out, people change right away. Best example that I know of, that I use, not that I know of, but that I use is the hormonal therapy in postmenopausal women. Evidence came out that it didn't work as well. Utilization dropped immediately. Breast cancer incidence dropped pretty rapidly at that point. It's trended back up for reasons that I don't think are relevant to this discussion. But the gynecologists were very upset about the way that was handled, and there's been a balance over time. But that was an example of when the evidence made an immediate change. Generally, evidence takes a long time. The PSA test is an example in oncology. People came out and said, the studies we're never done. We're never done to show that it made a difference. There were, some people felt it did. They still feel it does. But then the studies came out that went in a different direction. Now we sort of reached a balance. We have treatment where we don't treat people, where we follow them. And some people do need treatment, and more the discussions become what's right for you as an individual, as opposed to I'm a doctor, I think this works. We've had a long history of patients, consumers, and doctors thinking something works, and when the evidence shows up to say it doesn't work the way you thought, we need to become more responsive to understanding that evidence.